around 10-15 minutes, but that's okay. That's part and parcel of life. Okay, so good afternoon, everyone. So I'm Dr. Nilesh Bhamare. I'm a consultant pathologist in the Manipal TRUtest at Mumbai Central Processing Unit. So today's webinar, I will be conducting on recent advances in lab diagnostics. Actually, the recent advances, it's a very broad terminology. A lot of advances has happened in the field of pathology in various subspecialties of the pathology, particularly like hematology, cytopathology, histopathology, and even the molecular pathology. And across the various departments of the lab, microbiology also. So it will be a vast topic if we cover all specialty and all newer tests in a single webinar. So we will have a series of webinar particular to particular technology and particular advances in the subspecialties. In this particular webinar, we will just cover some recent new tests which are not commonly frequently asked nowadays, but they are important in the diagnostic as well as the prognostic point of view. So basically, coming to the hematology, if we consider there are a lot of newer techniques in hematology which has come, but as I earlier said, we will describe all this technology in subsequent webinar series. So today we discuss some few markers in the hematology which are useful in diagnostic certain conditions. Okay, just a minute. So when we talk about the hematology, the first thing comes in your mind is anemia. So up till now, for anemia screening, we usually used to depend on these routine markers like iron studies and serum ferritin. And we very well know that these tests are useful in classifying the various anemia depending upon their pathology. Like iron TIBC and transferrin saturation, these all parameters are decreasing. These are decrease in iron deficiency anemia, and total iron binding capacity increases. In similar manner, in anemia of chronic diseases, all these parameters are a little bit decreased. So up till now, we are using all these parameters, but there are two recent tests which can be useful in the screening of this disorder as well. Particularly, look at the bottom, the serum soluble transferrin receptor and serum hepcidin. So these two tests are there since last few years, but these are, I will still call them as a recent newer test in the hematology, because these tests are not frequently asked, like we do iron studies and ferritin level. So these tests are not that frequently asked, or even many of us, including the clinical fraternity, is not aware of these two tests. So that's why I want to focus on these two tests. As you can see in the table, the soluble transferrin receptor is increased in iron deficiency anemia, while it is normal to decrease in anemia of chronic disease. So in that way, this soluble transferrin receptor has an inverse relationship with the iron status, while hepcidin has a direct relationship with the iron status. Whenever there is a depletion of the iron, the hepcidin also goes on decreasing, and when there is iron excess, then hepcidin is increased, like in anemia of chronic disease. So how these two parameters work, we will look into the subsequent slide. But I want to focus on these two markers, the soluble serum transferrin receptor and serum hepcidin. It's not going. Next slide. Just a minute. It's not moving. Yeah. So basically, what is the this transferrin receptor? Basically, iron in the plasma is carried out by transferrin, and which interact with the cell through a specific membrane receptor, that is the transferrin receptor. And this soluble transferrin receptor is nothing but this is like the truncated portion or truncated monomer of this tissue receptor, and which circulates in the plasma as a complex of transferrin and its receptor. So this soluble transferrin receptor, it is secreted by erythroblast rather than the reticulocyte. So that's how this it's a marker of erythroblastic activity. Similarly, this concentration of serum soluble transferrin receptor is an indicator of iron status. So as I already said, there is an inverse relationship between the iron and this transferrin receptor level. The iron deficiency causes the overexpression of this soluble transferrin receptor, and while the iron repletion or iron excess causes the decreased levels. Just a minute. It's not moving. Hello. Yeah. So measurement of this transferrin receptor is very useful to understanding the pathophysiology of anemia. It is also the absolute marker of erythropoiesis. Since it is secreted by the erythroblast, it is a marker of erythroblastic activity. So in that way, you can also determine the adequacy of the marrow. So it's indicator of marrow proliferative capacity for any given degree of anemia. So because it is a marker of erythropoietic activity, you can also monitor the response, erythropoietic response to the various forms of the therapy, particularly allowing to predict the response when the changes in the hemoglobin are not yet apparent, because the changes in the hemoglobin happens quite late, but the changes in the level of the transferrin receptor happens quite early. So you can actually predict the response to the therapy. Also, this soluble transferrin receptor, these are the characteristic feature of the functional iron deficiency. Functional iron deficiency means you have the adequate iron stored, but at the tissue level, there is a deficiency. So if by just measuring and the HP and the ferritin, you will not have the idea of the functional iron deficiency. For that, you have to depend on this soluble transferrin receptor. So in that sense, it's a very useful marker. So soluble transferrin receptor is not only helpful in diagnosing the iron deficiency anemia, but it is also helpful in chronic anemia of chronic diseases. Because up till now, we are dependent upon the ferritin as a marker of reservoir of the iron. But we all know that the ferritin is also the acute phase reactant. So it is elevated in various states of inflammation. So because of that, you may have false impression that the iron store is normal. If any particular person or the patient has a iron deficiency along with the chronic inflammatory condition, so in that condition, we cannot depend on ferritin to assess the iron balance, because ferritin is as an acute phase reactant. It goes on increasing on this chronic inflammatory condition, and in that way, we have the false impression of adequate iron status. But the biggest advantage of soluble transferrin receptor that it is insensitive to inflammation. Since it is insensitive to inflammation, the levels are not affected by the inflammatory condition, and in that way, you can depend on this test to assess the iron status in anemia of chronic diseases, particularly. So in that way, it is very helpful in evaluation of iron deficiency in a patient who have inflammatory condition associated. It is particularly useful in cystic fibrosis. These patients particularly have the frequent inflammation and infection. So in that condition, this marker is useful. Even in insulin-dependent diabetics who may have iron deficiency resulting either from gastric atrophy or gastric autoimmunity. So ferritin will not be that much reliable because of the associated. So depend on this.
हाँ और सुनो 3 बोले कह जाओ यार वो दही बल्ले यही 3 दही बल्ले हाँ वही पापड़ी वाला है जल्दी लेकर आओ यार कब से कॉल कर रहा हूँ तुम पता नहीं कहाँ रहते हैं इधर चक्कर मत रहा करो यार ठीक है जल्दी जाओ.
So another marker is hepcidin. So hepcidin, this is a major regulator. You can say the key regulator of the iron homeostasis. And hepcidin has an inverse direct relationship with the iron status. So what does the hepcidin do? Basically, hepcidin level, it increases hepcidin level. The function of the hepcidin level is basically to reduce the iron absorption from the duodenal enterocytes, and it causes the iron accumulation in the macrophages particularly. So hepcidin level increases in response to the iron sufficiency or iron overload. So thereby it decreases the intestinal iron absorption and inhibit the release of the iron from the iron store or the macrophages. Similarly, when there is an iron deficiency lowers the hepcidin level. Since the hepcidin level is lowered, it leads to the enhanced iron absorption from the duodenal enterocyte and release of the iron from the iron store, that is the macrophages. So that's why how it regulates the iron balance in the system. So these are the key regulator of the hepcidin, particularly whenever there is an iron overload, like RBC transfusion or IV iron supplementation, or whenever there is excess of iron overload in hereditary condition like the hereditary hemochromatosis or certain infection, then all these factors then stimulate the hepcidin level. Then hepcidin will inhibit the iron absorption from the enterocyte, and it also inhibit the release of the iron store from the macrophages. So in that way, it maintains the iron homeostasis. So these are the positive regulators of the hepcidin. Then which are the negative regulator of the hepcidin? So whenever there is a anemia, hypoxia, or ineffective erythropoiesis, or chronic alcoholism, or chronic HCV infection. So in all these conditions, inhibit the secretion of the hepcidin. So which leads to increased absorption of the iron from the enterocyte and release of the iron from the macrophages. So these are the positive and negative key regulator of the hepcidin. So where the hepcidin is useful. So basically, hepcidin is very useful in diagnosing certain conditions, like the diagnosis of insulin, this iron resistance, iron deficiency anemia. So iron resistance, iron deficiency anemia, it's basically genetic disorder caused by mutation in the hepcidin inhibitor. And because of that, there is appropriately a very high level of the hepcidin in these patients. So because of the high levels of the hepcidin, iron cannot be absorbed from the intestine. So because of that, the oral iron therapy is not useful in this particular patient. So patients do not respond to oral iron therapy, and the only option left is the parenteral iron therapy. So in that way, we can decide the line of treatment in this patient by just estimating the levels of the hepcidin. In classical iron deficiency anemia, hepcidin level is suppressed. It is suppressed up to below the limit of the detection. In classic IDA, I'm saying, but in iron resistance, iron deficiency anemia, hepcidin level is inappropriately increased. So if this hepcidin test is used in appropriate clinical context, like suppose a young patient with unexplained iron deficiency anemia not responding to oral iron therapy, and if the patient has a positive family history, then we can definitely narrow down to the diagnosis of iron resistance, iron deficiency anemia, even without doing the molecular testing. So that's the importance of hepcidin level. It has to be used in a clinical context, and if you use it with the clinical context, then this marker can be very helpful in determining the pathophysiology of various causes of anemia. Okay, so hepcidin is a very well marker in diagnosing the anemia of the chronic diseases, and nowadays many clinicians are depending on this parameter, and the results are also quite good in diagnosing the anemia of chronic diseases particularly. Hepcidin level also help in diagnosis of other atypical macrocytic anemia, due to some rare genetic disorder of iron metabolism and heme synthesis. So another use of hepcidin is diagnosis of iron overload disorder. So iron overload disorder, the most common one is hereditary hemochromatosis. Classical type is the commonest genetic disorder. Atypical hereditary hemochromatosis account for 35 to 40% of the cases. Actually, in this hereditary hemochromatosis, hepcidin levels are typically low to the normal range. Ideally, in hemochromatosis, there is an iron overload. So ideally, one should have the high levels of hepcidin. But in this condition, there is a low levels of hepcidin, and because of that low levels of hepcidin, the iron is absorbed more from the enterocytes, duodenal enterocytes, and more iron is released from the macrophages. So in that way, hepcidin is the high levels of hepcidin is because principally responsible for the iron load in patients with the hereditary hemochromatosis. As already described, hepcidin can be used in diagnosis and management of iron deficiency anemia, very useful in distinguishing between the iron deficiency anemia and anemia of chronic diseases. Because in IDA, usually hepcidin level is low to the normal, but in ACD, hepcidin level is invariably increased. Hepcidin discovery has also opened a lot of opportunities to develop the newer kind of the drug, and a lot of many hepcidin agonist and hepcidin antagonist are under pipeline of development. So hepcidin agonist, they can be used in the treatment of iron overload, while hepcidin antagonist, these can be used in the treatment of iron deficiency anemia and anemia of chronic disease. So these kind of drugs are still not yet in the market, but definitely sooner or later, these will become the mainstream of drugs. So up till now, we have seen the hepcidin level is useful in both in diagnosing the patient as well as the monitoring the effect of these novel therapies. So once we gone through this, whenever we want to assess this vitamin B12 status, so which is the better test? That is the question. Either it is total vitamin or active vitamin B12. Up till now, we are depend on total vitamin B12, but is it right to just depend on total vitamin B12? Or why should not we try to measure the levels of active vitamin B12? So let us see. So basically, the main reason behind that is not all vitamin B12 is metabolically active. So out of the total vitamin, 70 to 80% is biologically inert. That is bound to holohepatoprotein, which is an inert portion of the total vitamin B12. And about just 10 to 20% is biologically active form, and that which is bound to the transcobalamin. So only B12 which is bound to transcobalamin is a biologically active form, and this is the only form in which the vitamin B12 enters into the cell. So that's why it is a biologically active form. Once the vitamin B12 bound with the transcobalamin enter into the cell, then it is converted into methylcobalamin, adenosylcobalamin, and then further it takes in the pathway of homocysteine metabolism and methylmalonic acid metabolism. So when we compare the B12 versus the HoloTC, so as earlier mentioned, the HoloTC is metabolically active portion, and it is the earliest parameter that becomes decreased when we suspect the negative vitamin B12 balance. Measurement of the total B12 has a poor sensitivity and specificity in predicting the B12 status, because 70 to 80% of the total B12 is biologically inert. If we just measure on vitamin B12, then many of the vitamin B12 deficient subject would have been overlooked if we only use vitamin B12 as a screening test. HoloTC also, it is independent of recent absorption of vitamin B12. This is particularly when whenever the patient takes the vitamin B12 supplements orally or parenterally, you may see within a single injection, you may have the vitamin B12 level more than 2000 or something like that. But that does not give you the correct idea of this vitamin B12 status. Since HoloTC is independent of this recent absorption, so you can rely on HoloTC more than B12 in such conditions. Even the half-life of the HoloTC is shortest, so that makes it the earliest marker to appear in the serum whenever we suspect the vitamin B12 deficiency. And remember one thing, only B12 which is attached to transcobalamin is able to enter the cells in the body. HoloTC is the most useful marker than total B12 in the serum. So actually how the B12 deficiency developed, this is like the recent hypothesis. Whenever there is a normal B12 status, you will have the normal levels of total B12 and the HoloTC. Whenever there is a B12 depletion, when the depletion begins, earlier there is a depletion at serum level and there is a depletion at cell level. So in these both the condition, the earliest marker to go down is HoloTC, that is the active B12. So in depletion, the active B12 go down to the normal than the normal level, but total vitamin B12 level can be still normal. So when does this total B12 go down? Only when there are the symptoms of the B12 deficiency develops. When the metabolism is already damaged and there is our clinical signs and symptoms and some irreversible neurological damage, at those conditions total B12 can be significantly on the lower side. So this shows how the HoloTC is the earliest marker to appear whenever the B12 deficiency start to develop. So we can detect the B12 deficiency at the level of earliest level by measuring HoloTC. So that is the advantage of HoloTC over the total B12. So how we diagnose the B12 deficiency subject? So if we do if the total B12 level is usually hello, please unmute yourself. So whenever the total B12 level is less than 150, these patients are likely deficient of vitamin B12. If the total B12 levels are between the 150 to 250, this is a gray zone area particularly. So in this particular patient, you need to do additional testing like the HoloTC, because if the HoloTC is normal in this condition, then you can then there is a very rare chances of developing the B12 deficiency. And whenever the B12 level is more than 250, then these patients are unlikely to be deficient of vitamin B12. Okay, so this is about the HoloTC. One more marker in the field of hematology is immature platelet fraction. Many of us are aware of that immature platelet fraction very well, and many of the clinicians are now started using this test. So immature platelet fractions, platelets are nothing but these are the young platelets. These are the newly released platelets in the peripheral blood from the marrow, and these are larger and more reactive than mature platelet. These immature platelet contain the RNA. In a similar manner, like in reticulocyte, particularly, we have the RNA content. Reticulocytes are nothing but the young immature and RBCs. In a similar manner, these immature platelets are nothing but the young immature platelets with the RNA content, and that's why they are also called as reticulated platelets. So these reticulated platelets are basically detected in a fluorescent by flow cytometry by using the side scatter and forward scatter, because it contains the RNA which can be tagged with the specific dyes and can be detected by flow cytometry very accurately. So basically this IPF is an index of thrombopoiesis, and we can determine the mechanism of thrombocytopenia. Because see, platelet counts are low because of either increased destruction or decreased production. If there is an increased destruction, then marrow is productive and the immature platelet fraction is usually on the higher side. It indicates the active bone marrow. When there is a decreased production happen because when there is a marrow suppression, particularly in cancer chemotherapy, plastic anemia, or marrow infiltration by secondaries. In that condition, marrow is hypoplastic. So immature platelet fraction is usually on the lower side. So in that way, by looking at the value of the IFF, we can determine the exact mechanism of the thrombocytopenia. So IFF is also the first indicator of the marrow regeneration. The reference range is anywhere in between 0.9 to 7, or sometimes it is 0.9 to 6.5, depending upon the analyzer we are using. So, immature platelet count is like an index of the thrombopoiesis. It assesses the reticulated platelet released from the bone marrow. Various studies shown have their normal ranges. As I said, it can be anywhere in between 0.5 to 0.9, and upper limit can be up to 6 to 7. So the IPF nowadays is very useful in assessing the platelet status with viral infection, particularly dengue or malaria or some other viral infection, because we all are aware that in all these patients there is immune-mediated destruction of the platelets and destruction of the platelet consumption by other mechanism as well. That leads to the hemophagocytosis. And usually, whenever the platelet count on the lower side, particularly after 30,000, 20,000, the main concern is about the platelet transfusion. Platelet transfusion is also preferred kind of treatment, but there is also a lot of risks involving platelet transfusion, like alunization, transmission of infectious diseases, diseases. So our goal has to be to reduce the platelet transfusion as much as possible. And for that, this IPF can work with. For example, if we look at the example, if we follow up on this is a follow-up in a patient of a dengue particularly. So as you see, as the viral infection progresses, initially the platelet goes on decreasing. Like you can see in the above table, the platelet goes on decreasing from 89 to 39 from day 1 to day 3. At the same time, immature platelet fraction goes on increasing from 7.8 to 13.9, because whatever platelet thrombocytopenia happening is dengue is because of the peripheral destruction, and in this patient, but the marrow is productive. So IPF is a marker of thrombopoiesis. So it indicates that the marrow is actively producing the megakaryocytes and the platelet. So that's why IPF goes on increasing initially, and at one stage, when the platelets start on increasing. In this case, on day 4, the platelets start on increasing from like 39 to 47,000, and gradually it goes on increasing in subsequent days. You can see that at that time the IPF start declining. Means definitely there is a correlation between the platelet count, what we are seeing in the peripheral blood, and IPF level, in particular monitoring the patients of the dengue or any other viral infection. So why am I showing this example? Because this marker can be very well used to assess the condition, whether the patient needs the platelet transfusion or not. Because IPF is a very good marker for predicting the platelet recovery in dengue patient having the thrombocytopenia or in any viral infection. If the value of the IPF is high, like say more than 10%, 10% is the cutoff. If it is more than 10%, then it indicates that the platelet recovery within 24 to 48 hours. So if you come to know that your platelets are going to recover within next 24 to 48 hours, then you can avoid the platelet transfusion. And just by avoiding the platelet transfusion, you can also avoid the potential transmission of diseases and other risk factors associated with the platelet transfusion. Okay, so it definitely avoid the bone marrow biopsy. to rule out the cause of the thrombocytopenia, and definitely avoiding the bone marrow biopsy is definitely a very obvious benefit for the patient. So IPF, the main feature of the IPF, it can differentiate between the consumptive versus productive reason of thrombocytopenia. IPF, you can consider mean platelet volume also as a, but along with the IPF, but mean platelet volume does not correlate well with the IPF, because since younger platelet are not necessarily larger. In MPV, we are looking at the larger platelet or giant platelet, but not necessarily they are young platelet or reticulated platelet. We are not interested in giant platelets. We are interested in immature platelet. That is the platelets which are released from the bone marrow. So IPF is much more better parameter than mean platelet volume. And this fraction works very well even with the very low platelet count. Even if the less than 20,000, the IPF is very useful in determining the platelet recovery. Okay, so we are already running very short of time. So I will just, beside hematology, we will just discuss few markers in immunoassay very rapidly. So calprotectin is a marker of gastrointestinal inflammation, because calprotectin is a calcium and zinc binding protein, which has an antimicrobial property and which is present in the cytoplasm of the neutrophil. So that's make it very special. So whenever the calprotectin is detected in the feces, it is an indirect marker of inflammation of the gastrointestinal tract. So basically, it is used to differentiate between the irritable bowel syndrome and inflammatory bowel diseases. Lifestyle modification, behavioral modification, and that is, while the inflammatory bowel disease is like a very serious pathological condition. It's a serious inflammatory condition. You can have the lot of red flags on histological examination. It often need the endoscopy, and treatment include a lot of immunosuppressive and anti-inflammatory medication. But irony is that the symptom of both the condition are nearly the same. The patient will have the abdominal pain, the altered bowel habit, and the impairment of quality of life. So the symptoms are quite overlapping. So it is very important to differentiate between these two conditions. IBD, we have like Crohn's disease, ulcerative colitis. We all know that, and these are very, if ignored, the life-threatening condition. So calprotectin is a very sensitive marker of inflammation, and it is useful for differentiation between the IBS and IBD. It is not only useful in diagnosis, but it also monitor the disease activity, and also helpful in treatment guidance, and also predict the relapse of the disease and post-operative recurrence. So this is just a flow chart. Basically, whenever a patient comes with this kind of symptom like abdominal pain, change in bowel habit, bowel loss, iron deficiency, anemia, either then you can go for fetal. If the symptoms are quite severe and you can suspect on inflammatory bowel disease, you can directly refer to the gastroenterologist with the gastroscopy. But if symptoms are not severe, then you can do this fetal calprotectin test. And whenever the levels are less than the normal, then levels are less than 100 microgram per gram, then you can suspect the IBS if the patient has the symptom. Whenever the levels are in the gray zone area, particularly 100 to 250, then this patient can be evaluated for other causes of gastric infection, and this patient can be re-evaluated after a few weeks. But whenever the levels are more than 250 microgram per gram, then it is highly suggestive of bowel diseases. So this is how we can use this test to differentiate between the IBS and IBD. So in pancreatic function test, we will just discuss one test which determine the exocrine function of the pancreas. And also order the pancreatic function test basically. So whenever the patient has the symptom of abdominal cramp, bloating, particularly the foul smelling, bulky, greasy stools, vitamin deficiency, malnutrition, malabsorption, and in children particularly inability to gain the weight or delayed growth, at that time you can suspect there is some pancreatic involvement. So you can go for pancreatic function test. So fecal elastase is like pancreatic elastase 1 is one of the indirect tests of the pancreatic exocrine function. Why? But why only fecal elastase, not?
Mango ice cream.
So pancreatic elastase 1 is basically human protease with elastic activity and synthesis of the pancreatic acid cell. And it's a marker of exocrine.
Powder
So particularly, it is a marker of exocrine function of the pancreas. Since pancreatic elastase is not degraded while it passes through the intestine, and it is more specific to pancreas, then this can be used as a sole marker for determining the pancreatic exocrine function through the feces. The level directly correlate very well with the pancreatic function. Why we are interested in knowing the pancreatic exocrine function basically, because pancreatic exocrine insufficiency can lead to chronic pancreatitis. Even the gallstone surgery, gastrointestinal surgery may lead to pancreatic exocrine insufficiency. Even in the diabetes, since India is a world capital of diabetes, the prevalence of pancreatic exocrine insufficiency is very high in the type 1 diabetes as well as in the type 2 diabetes. So it's very important to screen for the pancreatic sufficiency in a patient with the diabetes. So we can prevent the pancreatic exocrine insufficiency and subsequent development of the chronic pancreatitis. This pancreatic fetal elastase can be used to whether there is to diagnose or exclude the pancreatic involvement whenever the patient has the symptom as discussed earlier. And it is used for diagnosis and exclusion of pancreatic insufficiency. Pancreatic insufficiency usually develops in many conditions, particularly most important are chronic pancreatitis, cystic fibrosis, diabetes, even in IBS and IBD. So we can diagnose the pancreatic exocrine insufficiency by measuring the pancreatic fetal elastase in a smaller amount of the stool sample. And in that way, we can prevent the chronic pancreatitis, and which is pancreatic cancer, because this chronic pancreatitis is also one of the important risk factor of the development of pancreatic cancer. In gastric function test, we have pepsinogen 1, pepsinogen 2, gastrin, and H. pylori IgG antibody. These are all indirect tests from the blood sample. We are not discussing the direct test, gastric function test. Basically, pepsinogen 1, pepsinogen 2, these are released from the corpus. So whenever there is a pathology in the corpus, then you will have the fluctuation in the level of pepsinogen 1 and pepsinogen 2. So these levels are increased in cases of gastric inflammation, particularly by H. pylori, and inflammation due to other reason like bile reflux or chronic alcoholism. But whenever there is an atrophic gastritis, the level will go down. So pepsinogen 1 and pepsinogen 2 ratio, this is very useful in diagnosing the atrophic gastritis, because the ratio, the lower ratio is seen in atrophic gastritis. Similarly, gastrin is secreted by the gastric antrum, the G cell of the gastric antrum, and it acts on the parietal cell to secrete the HCl. So gastrin level can be decreased in cases of the atrophic gastritis. So in a way, we can detect the atrophic gastritis by measuring the levels of the gastrin, pepsinogen, and pepsinogen 2. So we can screen the atrophic gastritis by doing these tests from the blood sample. The screening, why the screening is very important in atrophic gastritis, because it is a risk factor for the gastric carcinoma and it also leads to malabsorption of various vitamin like vitamin B12 and various minerals like calcium, magnesium, zinc. So we can avoid this condition by screening for atopic gastritis. Okay, guys. So thank you very much. Within a limited period of time, I tried to cover few of the markers which are may be recent, may not be recent, but these are recent because these are not used to the manner, to the expectation of their potential. So that's why we have discussed these markers, and this is just the first edition of the recent advances. In subsequent edition, we can discuss the various technology in details and the various newer tests developing various specialties. So that's it from me. Thank you for your patience and thank you for the